So Axel, we've got a bunch of confused people sitting out and listening to us talk about RAS analysis and choosing therapies, and I'm confused as well. So what do
I hope not.
Yeah. So what do you say to patients? Where do they get this testing? Should they just go ahead and get it on the primary? What's going to be our party line right now?
So, I mean, if you test early, RAS mutation, before you use EGF receptor antibodies, RAS mutations are pretty much preserved unless you start putting patients on EGF receptor antibody. There are data that about 15-20% of patients on EGF receptor-based therapy, or anti-EGF receptor therapy, actually see the emergence of KRAS mutant clones. There are publications in Nature about 2 years ago now, with the beaming technology, liquid biopsies, where we can follow sequentially over time patients' kind of tumor load biomarker, as you know, much better. So when you know, the discussions we have with RAS and KRAS are very much the same. You just need to identify a lab that can do it. I mean, we have had this problem, or actually the privilege of explaining the KRAS story to patients since 2008. So we have developed verbiage to say, you know, you have this, if your tumor has this feature, you're not a candidate for that therapy. Now the question is, we add another 15% to the mix. We actually, every patient who comes to Mayo Clinic from outside and has a KRAS wild-type tumor, we retest. We test for extended RAS analysis, and there are commercial labs around. I mean, including Mayo Clinic labs, there are Foundation One, there are tests out there. I think it's not the availability of these tests, more knowledge in the community about the need to do this. Sometimes, you know, discovery, really searching for these tests, and then reimbursement.
But on that, there are also universities that will do the test for private practices.
No problem. I mean, you can find your local.
You can find it. That's the key take-home point.
So it's not. I think it takes effort to do that potentially, but once you've done it and you have established pathways, I think it's not different than what we've done with KRAS.
Yeah, and we've done this for lung. We've done this for breast.
Well, yeah, breast
and
broke
this is going to be
paved the way.
another step along the
Just,
way.
I mean, you know, do a lot of things.
Well, and I think it's important for the oncologists to communicate with their local pathology department to make them aware that this is now an expectation so that your local pathologist can help you expedite this whole system so that patients don't have to be subjected to lag times in getting test results. And I think as this whole era of molecular biology and testing and more enhanced patient selection moves forward, we as oncologists are going to have to be communicating with our pathologists that, you know, we now have treatments that are dependent on high quality laboratory assessment, and we need their help. It is a partnership that needs to be expanded.
You know, it's interesting. One of my partners actually says that molecular testing or approved molecular testing has actually become just as important as a baseline CT scan for some of the patients, that you just it's something that you're going to order along the way.
And it's not necessarily more expensive.
Yeah. Now, Tony, I'm going to have you touch on one more really interesting thing that Alan said about the 80405 data. 10% of patients went to curative resection. That just seems incredible to me and fantastic, right? Potentially curative resection. Tell me a little bit about how you put this into perspective, where we've seen the new EPOCH data, where they used cetuximab-based therapy, and it wasn't so good. Now, I know we haven't seen the data from 80405 yet, but what do you think there?
So there may be some differences between the two populations. You know, with the EPOCH data, these were clearly resectable patients, and I would think in 80405 these were borderline or initially unresectable. So maybe there may be some differences in the biology. There may be some differences in those populations. Certainly, until we dig further into this data, it would be difficult to compare the two. But nonetheless, this is amazing, and this is regardless of the chemotherapy backbone or the biologics. What we know is that we can render now a lot of patients resectable and on the path of perhaps a long disease-free survival and perhaps for a cure. So this is certainly great and confirms what we thought all along.
What I'd also add, and again, this gets back to continuum of care and guidelines. You know, we're now emphasizing to look for these patients. This is a real phenomenon, and it's been supported in other trials. The percentage may vary, but we need to be looking for these patients. And as clinical trialists now, we talk a great deal as we design first-line trials in particular. This population has become a new endpoint. We should be looking for these individuals in our trials. And we know when an oncologist first sees a patient, it may not be completely clear if they're resectable, if they're synchronous. They may be very reluctant to go right to surgery. You want to see, are these tumors that are chemosensitive? Is the patient going to benefit? But I think this just adds to the importance of looking for a subset of patients where they can enjoy really impressive survival.
I want to add to that, though, Al, because the common thought is, well, if you can go to surgery, then you might live a long time, and if you can't, it's all over, even though you're going to live 29 months. If you look back even at the old 97-41 data, there were a number of long-term survivors who only got systemic therapy.
That's true.
I only expect that fraction to increase as we go along this continuum that you raised.
Right, it was 8%.
Yeah, it was. It was really in the same range. It's really exciting.
And we don't know, it's impossible to know if this mattered, but one of the things that Chuck and I put into the protocol at the outset was for the physicians to indicate whether the treatment was as part of a strategy to render a patient disease-free or palliative. To my knowledge, I've not seen that done. And we actually mandated a surgical consult at the outset. Now, I don't think that every patient had a surgical consult. Yet many patients would have a look at this at the first analysis, the first assessment of their disease, would get another surgical opinion. And if we changed behavior at all, I don't know if we did, but if somehow we planted the seed, maybe that's what made the difference, because it is very unusual, I think, to see across, again, many centers all around all around the networks where these patients were being considered for things that many centers wouldn't have done before.
No, I mean, if all we did is raise awareness, that would be good enough. I still see patients coming to me who have failed first-line therapy with a solitary progressing liver met, and the consideration of surgery is not even raised to this day.
Yeah.
So we have so much data left.